Hello, world. I hope everybody's doing good on this Thursday night. Here today we have, once again, Dr. Bridge, Dr. William Bridge, psychiatrist. How you doing?
Hey Juan, I'm doing well, man. Thanks again for having me on. I'm excited to talk about this topic of anxiety.
Yeah, so am I, William. The topic for our second podcast is anxiety. And our first podcast was a very good podcast. It signified the difference between psychology and psychiatry. But this time we decided to talk about something that we all experience because anxiety is, is something that all humans experience to a certain degree. Would you not say so, William?
Yeah, absolutely. I think in most cases, some anxiety is entirely normal. Whether it's giving a speech in front of the class, or an important job interview, or seeing distant relatives. There's levels of anxiety, kind of in all of the scenarios of life, but we need to kind of identify what's normal, and when it becomes beyond that, and what to call it and what to do with it.
So one of the things, thanks for sharing that, William. And one of the things that makes this dynamic between us so interesting is that I'm a psychotherapist and you're a psychiatrist. And although we come from the same type of background, psychological background, we tend to have a different perspective of viewing things, which is something I love. And that's why I enjoy talking to you, William. I was reading recently, and this is something that I was taught throughout my undergraduate degree, that anxiety is a good thing. A little bit of anxiety is a good thing because biologically, through our evolution, anxiety kept us on our toes, away from tigers, away from bears, where to go and where to sleep at night, that where we feel safe, when to put out the fire at nighttime when we were primitive, and it's transferred over time. So a little anxiety, like you said, right before a job interview is a good thing because it makes you aware that the way you're going to present yourself is important. Um, but anxiety, by its clinical definition, such as something like generalized anxiety disorder or social phobia, is an intense feeling or intense emotion um, in which a person meets a certain criteria to meet a diagnostic term diagnosis. When is it too much anxiety? When is it not? What's the difference between anxiety and nervousness? And these are all things we're going to talk about in this podcast. So I think the best thing for us to do, William, is to define anxiety by its actual definition. Do you mind if I quote the American Psychological Association in what is anxiety?
Yeah, no, I definitely like to hear how they outline it in their guidelines.
Okay. Anxiety, quote unquote, is an emotion characterized by feelings of tension, worried thoughts, and physical changes like increased blood pressure. Uh, People with anxiety disorder usually have reoccurring intrusive thoughts or concerns. They may avoid certain situations out of worry. They may also have physical symptoms such as sweating, trembling, dizziness, and rapid heartbeat. So anxiety is something that's very intense. It's not a little bit of nervousness that you feel right before a job interview or right before meeting distant relatives. It's something that actually affects your daily life. That it affects it. This intense emotion affects it so much that you can't proceed throughout your workday. You can't proceed without the normal daily activities that are happening in your life. Is that not accurate in the way you view anxiety in your psychiatric in your field, William?
Yeah, I mean, absolutely, I agree. When it comes to anxiety, and I think what, that definition is outlining is that, you have significant distress as a result of the anxiety, so you see in multiple settings, whether it's at school, personal life, at home, at work, and, maybe that anxiety spills over to multiple settings, but there's distress and impairment in your everyday functioning. Now, I once heard anxiety described as the feeling when you trip and you're falling towards the ground, and it feels like the ground is rushing up at you, but only instead of it lasting for 2 seconds, it lasts for, the day, or, in excess of a week, or even longer some cases. So that really stuck with me because it shows the level of impairment that severe anxiety and panic can really instill in somebody. So it's a very real world example. So that's something that really stayed with me after I heard that.
Um, William, let's clarify for the listeners the difference between nervousness and anxiety. To me personally, nervousness to a certain degree is a decent thing. It's something good. It can be productive because anxiety is thinking about something that may happen. And although it's important, like Sadhguru says, and the Dalai Lama, to live in the present moment, our ability as human beings with the most complex organ known to humankind is the brain. One of its abilities is to think ahead and to plan ahead and to foresee events and patterns that are going to happen. And that, and I think that to me is a little bit what I call nervousness or anticipation. But if someone says on the street right now, William says, I have anxiety right now, this event is causing me to feel anxious, are they using that word anxiety or anxiousness properly?
Yeah, so if it's anytime it's an isolated event that is tied to a specific, trigger, so if it's every time that they have to give this speech for their public speaking course, that's the only time they're anxious. That's what we think about is, a normal level of, nervousness. And like you said, it kind of challenges you to focus leading up to the speech, prepare, give a lot of energy towards, being comfortable with what you're saying. So, the popular saying is the pressure is good for you. You hear that a lot. So I think that's what they're talking about. A little bit of, nervousness kind of gets the wheels rolling and gets you motivated to be as prepared as possible. When you talk about, clinical anxiety, depending on which one you're talking about, we're really looking at, excessive anxiety that has physical symptoms, and it has at least gone on for a good 6 months in multiple settings of their life. And, on a basic, screening question that I ask some patients is, what areas of their life do they have anxiety about? And, a quick way to remember this is, kind of running through the F's, which include friends, family, finances, failure, future. So these are kind of, common, areas of life where, you're thinking to yourself, do I worry that my friends are not safe? Do I worry that my family is not healthy? And this is worrying. Everybody worries about things at some point that maybe they didn't need to necessarily worry about. That is normal. But when you see multiple facets, linked to anxiety that disrupts an ability to function, that's kind of when we talk about like a clinical or diagnostic type of anxiety.
So basically, if it's okay for someone who says I feel anxious, but most of the time it's going to be based on a particular setting or a trigger or a particular time. And I think the specific example used, if you have to use a speech, right? So this particular time, every time you have to do a speech in front of a class, someone may feel anxious and they may
Mm.
meet the symptoms of someone. The physical symptoms, they start sweating a lot, they get nervous, they're lost for words. But when anxiety has occurred for a certain time period, and we're going now off the DSM-5, the latest model, where someone's for over 6 months, over multiple settings, is also experiencing physical symptoms that's not allowing them to be productive individuals in their daily life during their normal typical routine, then that's when someone starts meeting the criteria, and it goes beyond nervousness. It goes beyond feeling anxious because of a particular event. It starts meeting the criteria for generalized anxiety disorders or other type of anxiety disorders. Is that right?
Yeah, I mean, absolutely. So, what you outlined there was definitely the most common type of anxiety disorder, which is generalized or GAD for GAD, generalized anxiety disorder, is really what is most commonly diagnosed, under the anxiety umbrella. And really, I think that, just as you put it, that excessive anxiety is on more days than not. So if a patient tells you, during the work week, I work 5 days, my weekends are fine, but on 4 out of the 5, work weekdays, I have anxiety that prevents me from getting my work done. And it's now put my job at risk because I'm falling behind. People don't know how to approach me, so on and so forth. So, on more days than not, over here, set. So that is going to be your generalized anxiety disorder, and that's when you start teasing out, okay, what's the next best step here?
So nervousness is almost just a moment, and the generalized anxiety disorder, as you said, GAD, is over a series of multiple settings. How let's move on to the next topic, if you don't mind, William, which is what's the difference between anxiety and panic? And I think that's another important term and difference. To me, panic is an excessive is an excessive not excessive, but it's an extreme emotional feeling for a moment, but it's not something that's carried out throughout the day. It's just almost like a yeah. Actually, what is the difference between nervousness and panic?
Yeah, so really, what I would say then is that when I think about panic, I almost think of panic as, if you ever turn on a garden hose and the water can kind of get, going through the hose before it comes out. That's more of a anxiety that kind of builds up to a point where it then exits the hose. Whereas, panic is a light switch. You hit the switch and it's kind of, a surge of unexpected fear. And that fear leads to physical discomfort and physical symptoms. What are those symptoms usually? It's usually like the fluttering in the chest, or as we say, like palpitations, abrupt onset of sweating, maybe even some difficulty breathing, or almost like a heated, like flushing of the skin, or chills, where it's more like the goosebumps and cold sweat type picture. So panic is, abrupt onset and very physical in its manifestation. So, you get those feelings, and usually you can tie it back to a trigger, and, what can trigger it, more common than not, the trigger, or a lot of times, what leads up to a panic attack, which is what I'm describing here, is actually anticipation of another attack. So you actually have anxiety about the possibility of having a panic attack. And it may be a little bit complicated, but I think it really shows how invasive and how disruptive these disorders and these symptoms can be.
Well, if once a person starts feeling anxious about the possibility of having a panic attack, it sounds like a vicious circle they're trapped in. That sounds so horrible. The this is great information for the public, William, and I appreciate you sharing it.
Sure.
But let's switch it up a little bit, if you don't mind. You said panic is a light switch that, and it could always be put down to a trigger. It could always be pinpointed to a specific trigger, and to me that sounds associated with trauma, because a lot of the clients I see, they may not be diagnosed with post-traumatic stress disorder, but they've definitely experienced trauma in their lives. And so a lot of times an event will happen. Let's say I work with adolescents, so an event will happen in school where the teacher is very authoritarian, and all of a sudden they have someone that the teacher's telling the kid, hey, you have to sit down because those are the rules of the class. And all of a sudden the kid, he'll start acting out even more because he has now an authority figure that's telling him sit down, which is what he may be experiencing. And it happens on an unconscious level. He had a dad who was excessively authoritarian, and that's why he's now basically meeting the criteria for oppositional defiance disorder. He's being very defiant. The teacher just triggered him. And so that is so interesting for the public. And these words get thrown around a lot, and they cross paradigms. And it can be very easy for the typical person to get confused or to understand the abstract lines we're talking about. But they do exist, don't they?
Yeah, certainly. And I think, you brought up a really good point, and that is, if you have somebody, when I think about, a patient, and you map out like a differential diagnosis. So we know there's a pathologic level of anxiety, but what category or what diagnostic criteria does it fall within? And that is important because it determines treatment moving forward. So when I think about PTSD or post-traumatic stress disorder, I think that very important to emphasize is that there was an exposure to something that is extremely threatening, okay, whether it was a near-death experience or military situation or situation of crime in the city or whatever the case may be. There was an actual threat that is time-stamped in the memory, and the memories surrounding that that traumatic event, will basically trigger a lot of hypervigilance or nightmares, flashbacks where they feel like they are reliving that prior trauma. So if you have a PTSD diagnosis, it's possible, but it's unlikely. If your anxiety is all drawn back to that traumatic event, that is not a generalized anxiety disorder. You know what I mean? That is a different diagnosis because when you trace the steps back to where is the origin of the patient's anxiety, that is to that event, which is not the generalized type of anxiety we talked about earlier.
Mm. That's interesting. So when it's traced back to that event, then it can be they can meet the diagnosis for post-traumatic stress disorder, and that's very important and good information, William. So I'm gonna direct this a little different way.
Sure.
How do you think social media affects anxiety? Because there's many fascinating organizations online, reputable organizations, and that's important for me to say that word reputable. For example, such as the Anxiety and Depression Association of America. It's a known association. They use research, the latest research, to talk about certain topics. And one of the topics they recently wrote about was social media obsession and anxiety. And they say that through research that too much social media exposure can lead to not only anxiety, but depression, attention deficit disorder, ADHD, from what I was reading earlier to
Yeah.
get ready for this podcast. And that's something that a lot of people tend to ask me, the effects social media can have on, a person's well-being. And so they may be asking, I think I had one time someone ask me, how is that possible? How can social media affect someone's overall mental health? And instinctually, I immediately thought about how even myself, when I post on social media, not through Psych Life, through my personal page on Facebook, which I barely use anymore. But when I do, it's always a picture I look good in, or it's always a picture where I'm trying to give a persona, and it happens in an unconscious level. So if I start scrolling through the Facebook feed, all I'm going to see is the best version of everybody. And almost like if everybody's living the good life, like no one has to pay bills, no one has hardships in their relationships or difficulties or struggles. That's one way that social media may cause anxiety and make someone feel almost lack in self-confidence and lose their self-worth a little bit. Do you mind touching on that? Because this is a new time and everything's changing so fast, William. Before, the changes, let's say in 30 years, were minimal as far as society was concerned compared to what the changes in about 5 years differences in today's society.
Yes, I mean, it's a whole different avenue of, anxiety and, some of the challenges we see with self-esteem as a result of social media. I mean, social media, on one hand, is really, some of the most fascinating technology and communication that we have. We can reach, so many people at any given one time using, something as simple as a podcast or, a video post. And, they used to say, to be happy, you really need only a couple things. One, don't compare yourself to others. And two, no matter what, don't compare yourself to others, right? So, I mean, I think that what, anxiety has been driven by social media is because, you see exactly what you were touching on. The patients or people all over the world posting the best absolute highlights of their last month on a few pictures, and you don't see a lot of negative. But it's innate in us where we see a picture, either somebody's car or somebody's jacket, and you think, I like that, I don't have that, or they can speak 3 languages, I always wanted to learn another language. So you just chronically kind of think of things that you see that you don't have, that somebody else possesses, or a skill or a talent. And the thing about social media is that it doesn't sleep. So we have access to it all the time. It doesn't close at 5 p.m. So you always have the access to it. And it's kind of, like you said, it's a vicious circle, because you start to feel worse, and then maybe you get on there to find something that make you feel better, but then you can find something that makes you feel worse. So it's incredible and incredibly dangerous at the same time.
It's playing with people's emotions too, because people start comparing husbands, or what was my ex-girlfriend or boyfriend doing online, and it's just, I'm not telling people not to use social media by any extent on this podcast, guys, and I'm pretty sure Dr. Bridge, Mr. William over here, doesn't mean that as well. What we're just saying is that social media, when we're talking about the topic of anxiety, can definitely lead to that type of intense emotion within somebody. And it's because of the fact, like William said, that you're comparing yourself to others. And that's something to take into consideration. If you're spending too much time on social media, then that can be a definite issue for a variety of reasons, whether consciously or unconsciously. Not to mention some of the side effects it has when it comes to your eye strain and neck pain, lower back problems, by just looking at the phone and all this stuff. But I don't want to focus on that too much, because I'm also a user of social media. The only thing I will say is, when we do try, we are living in a day and age now where when we post something on social media, we have a tremendous impact. We have the opportunity to share something with millions and millions of people. And so instead of trying to share how big someone's booty is or how much money they have, I think what people should be sharing is positive information and knowledge and education, because the world needs it. Now, William, when it comes to anxiety, let's focus now a little bit and change the avenue, make that, just change directions a little bit, and talk about substance use in relation to anxiety. Now, and this is a little bit of my specialty, William, because I work and I've been working at a rehabilitation substance use center now for about close to 4 years. And to us, the way the treatment center technically uses their approaches, they focus on the substance use, and then they focus on all the other factors involved, or the secondhand mental health diagnosis is involved, but they'll focus more on the substance use diagnosis. And that's important too. But if a kid is smoking pot and he's smoking pot on a bi-daily basis, and then the parents try taking him to court for a Marchman Act, I always tell the parents that I'm concerned about the pot smoking, because it can lead to other things, but I'm mostly concerned about his behavior, the way he's carrying himself, what his grades are like, is he going to school? But substance use can lead to anxiety. It can lead to depression, or excuse me, it can lead to it, but someone can be struggling with substance use and meet the criteria for depression and anxiety. That's the proper way to say it. What's your experience with this, William? And I'll share a little bit of my experience as well.
Yeah. So, my take on it is, I think kind of taking a step back is that, when we're talking about, the driving force of what's causing an anxiety, it's important to emphasize that, you need a clear point in their history when they are substance or medication free. And what I mean by that is substance or medications that could contribute to anxiety. So if you have something, like a severe cocaine addiction. If you're going to diagnose an anxiety disorder, you need to do so in a window of time when the cocaine was not involved whatsoever. So we do have either a substance-induced anxiety disorder or medication-induced anxiety disorder. And remember, we're talking about, a patient that, and when we talk about the difference of substance versus, medication, of course, substance kind of implies something that is either illegal or not prescribed.
Illicit.
Yeah, absolutely. So an illicit substance, but that can be something as simple as caffeine, mind you. It doesn't have to be something, like cocaine. And then medication. So what medicines can potentially cause anxiety? We think about, stimulants that we use to treat ADHD. We think about withdrawal from certain medicines that are used to treat anxiety. So overuse of anti-anxiety medicines can actually have like a rebound type of anxiety. So, of course, anxiety in these patients are going to kind of predominate the clinical picture. And basically all of the labs and history, physical exams, so on, basically point towards it's either substance or medicine that is triggering these symptoms of anxiety that we talked about with the palpitations and the racing heart and sweating. It's very common, and I think in some sense a lot of it is missed because. And, naturally, not everybody is upfront during that initial interview or evaluation about using a particular substance or overusing a medicine. It's not easy to admit that. It takes a lot of courage. And, I always commend patients, for being able to have the courage to come out with that early on in an interview because, it's admitting a fault. But it, goes to the, the idea that obviously this is somebody that wants help and wants to get past this.
So your experience is that oftentimes those that come in for the initial assessment, they're not telling the truth about the substances they're using. And obviously so, because they have no relationship with yourself, that you have to develop trust with them oftentimes. And that's the experience, William, that I tend to have as well. The initial intake takes a little while longer than a typical individual session. And clients typically aren't so forthright and honest as to how much they're using and what substances they're using. But if someone is, and you said it and you made it very clear, if someone, let's say, is smoking marijuana and all of a sudden now they've become a little bit more anxious, a little bit more paranoid, they don't meet and even though let's say they've been smoking pot for a year and over this time they've become more anxious, more paranoid, they may meet the criteria for, let's say, a generalized anxiety disorder, but they cannot and should not be diagnosed with that because it could be substance induced. And so that's important for the population to understand. When you're saying you're struggling, you're very anxious, you've been struggling with anxiety, you need to ask yourself, have you been engaging in substance use? How much have you been drinking? How much have you been smoking? Has your intake gone up over time? And this can be contributing to your anxiety. That's so important for the population to understand because people are misusing the word anxiety and saying they have anxiety, but when you ask them if they've ever been diagnosed, they say no. If you're saying that you're meeting a certain diagnostic criteria, I recommend going to see a mental health professional just so you can get the proper diagnosis and be honest in your initial assessment. So people like Dr. Bridge, who's here with us, can make a proper assessment, and someone like myself as well. There are many different types of classes when it comes to anxiety disorder, Williams. I'm just going to mention, I think there are 5, but I only wrote down 4 here. PTSD is one of them, generalized anxiety disorder, social anxiety disorder, and panic disorder. Am I missing one there, William?
Well, I think that, it depends on whether so that's definitely a comprehensive list, but, we have, the only thing that comes to mind for me is we have like these subsets of specific phobias. So when you have a patient that has an anxiety that is always provoked by a specific object, such as flying, heights, insects, injections, blood, so you have that. Then like the group, if you want to say, somebody has arachnophobia, that's where these terms come from. So this pervasive fear of spiders. And then additionally, there's also like an agoraphobia. So that's going to be usually somebody that has a fear of being unable or, not being able to escape in a situation. So, a lot of times people think it's the fear of going out into public. It's actually, they can go out into public, no problem. The problem then becomes when the large crowd rolls in and they have a fear about an inability to leave as they see fit. So these are, those are kind of very specific in nature, but you definitely hit the major categories for sure.
Okay, perfect. And just to clarify, when someone, William, you said there's a big difference. There's a misrepresentation when it comes to social anxiety disorder. It's not that people don't want to go outside or they can't. It's when the big crowd starts rolling in. It's when they're feeling pressured that they have to be a certain way amongst the crowd. And that's the social anxiety. The one that you were talking about where people, they can't go out, or it's not that they can't go out, it's that they try to limit themselves as much as possible. That's a whole different category that we're going to leave for another day. But just to clarify for myself, that's avoidant personality disorder, right? And that's a personality disorder that has nothing to do with anxiety.
Yeah, so we can absolutely. I mean, we could probably do an hour or 2 hours on each personality disorder, but I think of avoidant personality disorders that. So it's a generalized, as the term suggests, going out of your way to avoid people, situations, or family members, or engagements, and it's important to emphasize that those patients also long for that companionship. So they know that they have avoided it, but at the same time they have a desire to have that as part of their life. Because there's certain other personality disorders where they have a similar presentation, only they do not care, they do not miss it, and we distinguish it that way, and that's important, to emphasize. And of course, you can always have personality traits or personality disorder, in addition to these psychiatric disorders, such as generalized anxiety disorder and social anxiety disorder, which we didn't quite touch on social anxiety disorder or social phobia. Do you want to talk a little bit about that, or just kind of touch on that since we mentioned it and didn't talk about the specifics of it, or what do you think?
I actually was going to take the podcast to a turn to what the comorbidity scene with anxiety, but now that you mentioned it, if we want to share with the public, because once again, there are a lot of people out there that say, I don't want to do that because I have social anxiety disorder or social phobia.
Yeah.
And they're misusing that term. And that's one of the most important things. So let's talk a little bit about, I think there's five things that have to be met to meet the diagnostic criteria for social phobia. And one of them is a persistent fear of one or more social situations. And the second one is exposure to the feared situation, which provokes anxiety, obviously. And the person recognizes, and this one's important, that the fear is unreasonable, that it's not real, yet they're feeling it. So it's almost like a biological wiring where no matter what, even though the fear is not real and they know, individual knows they shouldn't be feeling this feeling of intense anxiety due to the social situation, they're actually experiencing it anyways. Am I on task here, Dr. William?
Yeah, that's on point. I mean, I think the kind of the hallmark feature that, if it's on my radar to, see if a patient, has this as part of their presentation, I ask about a fear of embarrassment. And it's interesting. I get a lot of messages on, Instagram about, Instagrammers that have fear of not getting enough likes, or anxiety associated with the negative comments that may come with a post. So, you know, not to loop back to what we were talking about regarding social media, but I think that in the future, as we modify and kind of refine these diagnostic criteria, I think, this social anxiety disorder, I believe, will be spilling over into the social media affiliated anxiety is one of the things I can see happening, because I get endless, messages, and, I have some of it myself. Before you post, there's the voice that mentioned, am I sure I want to say this or post this, or you kind of, second guess yourself. So, kind of have a fluctuating culture, but social anxiety disorder is becoming more common because the peek into somebody's life is far more accessible than it ever was. We have these, movie stars where, we see what, Will Smith is doing in his living room. We never would have thought that this type of, insight or availability to somebody's personal life would be available. And, here we are. So, I think that a lot of people will suffer from varying degrees of this at varying points in their life. And, it can be, you have this kind of perception of this major threat that is really out of proportion if you were to describe that threat to somebody who's not having the fear.
Which is why, honestly, William, I give you tremendous credit, because this fear that we're talking about, this intense social anxiety or social phobia, and you're correlating it with social media and that fear right before posting, is one of the reasons why I made this Psych Life logo, because to get rid of that fear and to get rid of that identification with myself, so I wouldn't feel so nervous when posting something, because it's almost like something that's I created, but it's not me. And so that's why I was just wanting to say I commend you for that, man, because you're willing to come here on this platform and share your tremendous knowledge. And I really, truly appreciate that. And I'm sure the population listening to this appreciates that. One thing I just wanted to add, though, with all these anxiety disorders, the one major similarity, besides the time and the moments when it happens, et cetera, is that it has to affect your life in a way where your daily living activities are affected and you can't perform them the way that you would or should be doing it. And that's important for people to understand when meeting the diagnostic criteria for any of these anxiety disorders that we mentioned. I think we mentioned 4 or 5 here, is that your daily life has to be affected because of meeting these criteria, the diagnostic criteria in specific. This is one, even though being a psychotherapist, I'm not too familiar with this part, William, and that's why I appreciate you on this platform. What are some comorbidities that are associated with anxiety disorders? And just so the population listening can understand what that word means, is other diagnosis criteria or that a person can meet along with anxiety disorder, aside from, let's say, substance use criteria, where the anxiety disorder was present before the substance use, because we talked earlier how someone's engaging in substance use, then they start meeting the criteria for generalized anxiety disorder. We cannot in good faith ethically diagnose them with it according to the DSM-5. Do you mind saying some comorbidities? Because from my experience, some of the comorbidities I've experienced, I don't even want to mention them here, because to me they're not necessarily I don't want to say real, but I don't have too much experience in it.
Sure. So, my take on it is definitely so, I think clinically, when we're looking at a patient, anytime they have more than one thing where you say there's a primary psychiatric disorder or diagnosis, you want to think to yourself, okay, what is the main thing? And, a very simple way at arriving, what's the patient identify as the most, disruptive part of why they're seeing me. And if they tell you it's the anxiety, chances are that the primary disorder is something along that anxiety umbrella. Now, when it comes to secondary or comorbid conditions, the most common thing that follows primary anxiety disorder would be a major depressive disorder. And I think I mentioned this, before. I think that absolutely, we need to, at some point in the future, maybe touch on depression because of the extent it's getting to, throughout the world. But definitely depression is probably the most common comorbid condition. And if you think about it, you take somebody with like a generalized anxiety disorder. Some of the descriptive things I say to patients is, it is like having your mind on a treadmill 24 hours a day, 7 days a week, 365 days a year. So if your mind is constantly worrying, every day, every waking hour, that becomes exhausting. What that leads to is it runs you down. You have fluctuations in your concentration. You're not able to sleep. You become more irritable, your appetite. So, anxiety can definitely drive depression. And the flip side of that coin would be a depression being the primary diagnosis. And let's say you have a depressed patient who, let's say a few months ago, they separated from a significant other and then lost their job, and they kind of, have irritability and guilt and poor energy and psychomotor changes and so on. If you don't have energy and motivation, what happens? Things pile up on you. Okay. And whether it's bills not getting paid or obligations not getting done or, task at work not being checked off, things pile up on you. And what does that do? That causes anxiety. So these two are so closely linked together that anybody that has one or the other, you can bet I'm asking about the other disorders. And then, also very common is insomnia, which again, I think talking about insomnia, we can talk about insomnia for probably 10 hours alone. But if you're not sleeping well, the next day doesn't go well, simply put. So if you're up all night, you're going to have a fluctuation in your concentration. You're going to be more irritable, shorter fuse, less prepared, more anxious, and they just kind of run right into one another. So insomnia, depression, and of course, dual diagnosis like a substance plus an anxiety disorder, that even if you hear an absence of the substance, they still had this baseline level of anxiety. Then these are things I think of, off the top of my head.
You touched on so many good things, William, which is irritability, decreased concentration, impaired sleep, which are overlapping symptoms for both anxiety and depression, and how one doesn't lead to the other. But if someone's struggling with depression and all of a sudden they're not sleeping well, then it transfers over to the next day. And now all of a sudden they're feeling anxious because they can't do their work properly and they might get fired. That leads to a whole set of problems. It's almost like a chain of events that happens. And I think that this has been such a great podcast. And I think one of the ways we're going to try and finish this thing, or the last portion of it, is what are some great treatment options and modalities for those struggling with any of the anxiety disorders that we talked about and mentioned here. And once again, this dynamic is between a psychiatrist and a psychotherapist. So although when I'm talking to my clients, I always try finding out what types of medication they're taking, but that's not my go-to. My go-to is always trying to help them develop coping skills, CBT, explain to them how their thoughts affect their feelings and their feelings affect their behavior, and the triangle that's within all of us. And then we try working on what's best with the client. Sometimes I'll focus on consequences, working with the parent, and in hopes that that'll help maybe touch the surface before we start getting into some deep therapy and they get to challenge themselves. Sometimes I have to work on their feelings in hopes that if they feel better, their attitude and their thoughts and their behaviors change. So, but in your case, it's a little different, William. You told me that I think it was in the first podcast, if I'm not mistaken, you're almost trained a little bit to look at um, what's going on in terms of the medication. It's almost but you also do some work, some clinical work, but it's also heavily medication based. So what type of treatment modalities do you engage in your profession when a client is struggling, and once a proper assessment is done that you get to see with the client?
Yeah, so I mean, I think of course, it's going to depend on what the patient's view is on the disorder or the anxiety. So they come in and we have usually that initial evaluation in the outpatient settings about 90 minutes. So comprehensive information gathering, and I think that you know I've said this before, so much of my job, I never thought in medical school that I would be saying this, but more than half of what I do is peel patients off of medicines. A lot of times they get referred to me by their primary care doctor or, family practitioner, because the anxiety has gotten to the point where they're no longer comfortable managing it, and they've kind of stacked up these medicines. So usually what I do is I take the patient's, a comprehensive history, and while they're talking, I'm thinking about either things that I can refine or, options that I can lay out for the patient so that we can kind of make a decision together. And, part of that may be no medicine, at least initially. And all of these medicines for anxiety work better when done in conjunction with, therapy. So, seeing a therapist, usually 2 times per week, if possible, for, extended amount of weeks until they are comfortable spacing out the session. So we can develop coping mechanisms that will always remain far superior to any medicine. So, having the ability to structure a plan to get through an anxious event, with, mindfulness and calling that friend that, can provide that support, or going to that park that is a peaceful place. So those things will always, exceed any of these medicines. So we need that really to be the backbone of treatment, having these reflexes that, prevent at any cost the habit of, okay, this is going on, here's this medicine. This is going on, I can't sleep now, here's that medicine. I didn't sleep well, now I'm depressed, here's that. So these medicines work well, but only when used in the right setting for the right diagnosis. So I see it all the time, sunlight, rest, fresh air, exercise, nutrition, water. These things, if everybody got more of it, these medicines would probably be cut in half, if not more.
I just want to touch on that. I'm so sorry, William, and that is tremendous information. So basically, the medication aspect of it, and I'm sorry I threw you under that bus. So like, if you're a medication expert, I shouldn't have done that. I didn't mean to come off like that. What I meant was, your stuff. That's what I should say. Your stuff, and you're saying to the audience that some self-care habits, such as your diet, how much water you're intaking, your sugar levels, what substances, or how much are you taking. All these factors contribute to anxiety levels, and that's more crucial. And especially since you're an internal medicine specialist, integrated medicine specialist, how much cigarettes you're smoking, all these things really, that's more important than just taking medication to reduce anxiety. And that is a message I want to get out there, make sure people hear it, because so oftentimes the population's miseducated, William, where they're going to the doctor to try and receive some sort of prescription just so they can relieve the symptoms. But the symptoms can be relieved with just some proper exercise, some daily exercise at a certain time, proper sleep, a change in diet. What are you intaking? Are you eating McDonald's 4 times a day? What's going on besides just taking a pill and just relieving of the symptoms? And really nothing's getting done, because the pill may stop the symptoms or inhibit the symptoms to some degree, but it doesn't extinguish in the long term, and developing of coping skills. Is that what I'm getting at? Because I think the audience needs to hear that. And if anything happens at the end of this podcast, I hope that's something they take away from, especially from a professional on this podcast, in Dr. William Bridge.
Yeah, so I mean, I think that, there is, absolutely a role for these medicines,
Yeah.
but my personal take, and, everybody's approach is a little bit different on this, is that, you know, uh, unless you have the routine and the preemptive plan to try to get out in front of the anxiety in other ways beyond medicines, you're going to completely end up reverting back to either going up on the dose or adding a separate agent. And I think that, when I treat anxiety, I really make it quite simple for patients. I tell them that anxiety comes in two forms. There is a baseline foundational level of anxiety that's kind of always present, humming, throughout the day, that's always there, kind of reminding you that you are anxious. And then there's kind of that tidal wave anxiety that comes in waves, and it gets you to a place that's extremely uncomfortable, where you have to step outside or you can't breathe. So I try to treat the foundational anxiety first. And what I hear almost all the time is that those waves are now not tidal in nature. Maybe it's just the tide, but it's not hitting you like a ton of bricks. So you control the foundation, the everyday type of anxiety, and then those episodes are far less, impairing. And that, anytime I start a medicine, I ask a patient, where is the point in your life that you can identify that things were ideal? What was going on? What was great about work? What was good in your family life? How was your relationship? How was your financial situation then? And then I ask them, what got you here? What has changed to the point where, you now felt that you needed help or medicine or therapy or all of the above? And if they can tell me what that is, usually it's a few things. We have to create a way to start peeling some of the negative tracks off. And every office visit, I'm asking questions to see if they're getting back to that bright place in their life.
All right, William. Thank you so much, man. I really appreciate you doing this with us on this podcast. You're part of the team, man, and you have such great knowledge and information. And anybody who talks to you is truly just becomes enlightened by just hearing some of the information you have, and your clinical knowledge is amazing, William. And I really appreciate you being on this podcast. I hope that we can do this again next week on a different topic. And it's always for the goal of promoting mental health awareness, and for the goal of just people listening to something where they can learn a thing or two. What do you think, William?
Yeah, absolutely, man. It was a really good talk. We touched on a lot of different things, and I hope that for the people that are listening that have been hesitant about either reaching out for help from their family doctor or their school counselor or whoever their support structure may be. It takes a lot of courage, to face your fears head on. So it was a great conversation. I enjoyed it, and as always, I appreciate you having me on.
Thanks, William. I appreciate that, man. Okay, so till next time.